Uh, Good afternoon, everyone, and welcome to our weekly multimodality imaging symposium. I'm coming to you from the DeBakey studio live, and with me is Dr. Nadeen Faza, who's one of our structural heart interventional imaging colleagues and an assistant professor of medicine. Today, we're going to be speaking with you about mitral and aortic regurgitation evaluation by echocardiography and by CMR. I'm going to have Dr. Faza speak first about assessment by echo, and then I'll speak afterward for valvular regurgitation assessment by CMR, and hopefully we'll have some time for questions at the end. So Nadeen, can you hear me okay?
Hi, Dr. Shah. Thank you for the introduction.
Great. Take it away, Nadeen.
Thank you. All right. Good afternoon, everyone. My name is Nadeen Faza. I'm one of the interventional imagers here at Houston Methodist, and we'll be talking about mitral and aortic valve regurgitation by echo. Yeah. We're going to be talking about echo first, but I'll make sure to explain why CMR is also very useful in the evaluation. This is my approach to regurgitant lesions. It's important to first define the mechanism, determine the severity, evaluate for consequences of the regurgitant lesion, because that helps you determine the timing and the different management options. I'll be basing my talk on these recent 2017 ASE guidelines, and Dr. Zogby, Dr. Little, and Dr. Shah were all authors on this very important document. Starting off with my favorite valve, mitral regurgitation. This is a picture of the mitral valve that really demonstrates the importance of the different, the papillary muscles, the cords, the leaflets, the mitral annulus, the LV, and the left atrium in maintaining the function of the mitral valve. So it's a very complex structure, and it really relies heavily on the interaction between all these different structures. Mitral regurgitation can be divided into two broad categories: primary mitral regurgitation and secondary mitral regurgitation. And this is the Carpentier classification of mitral regurgitation. If we start with the primary MR, this could be caused by leaflet perforation, a cleft in the mitral leaflet prolapse, or rheumatic mitral valve disease, mitral annular calcification, or drug-induced mitral regurgitation. Secondary MR is divided into atrial mitral regurgitation caused by atrial dilation, non-ischemic cardiomyopathy, and ischemic cardiomyopathy. Remember that the mitral world is a 3D world, and 3D TE really helps you localize the different sites of pathology. This is the surgical view of the mitral valve. The anterior aspect is usually where you'll find your aortic valve. The left atrial appendage marks the lateral aspect, and the interatrial septum marks the medial aspect. This is your anterior leaflet, and this is your posterior leaflet. 3D TE is very important, as I mentioned previously, for localization of pathology. This is an example of the P2 flail. This is an A2 prolapse, and this is a flail of the A3 segment right here, very medial, close to the septum. Examples of primary mitral regurgitation include this case of bileaflet mitral valve prolapse. You can see the bileaflet prolapse by peristernal axis views. This is the mitral regurgitation, which is appearing late in systole. So early systole, you don't see much flow. And this is very obvious still in this CW picture, showing no jet in early systole, followed by this late systolic MR. So it's important to describe the mechanism, the timing, in addition to the severity and the consequences of these regurgitant lesions. Another example, this is an ixomatous valve, TE imaging showing these diffuse thickening of the valves with bileaflet prolapse and an eccentric anteriorly directed jet. So I can describe the mechanism and the direction of the jet. This is a case of fibroelastic deficiency where you have a local flail rather than thickening of both leaflets. So you have normal or thinned out leaflets and a focal prolapse with a focal jet caused by this flail. Another example of primary mitral regurgitation. This is a patient who presented to us with a flail posterior mitral leaflet with a huge flail gap of 17 millimeters. He was a high surgical risk patient. So based on our heart team discussion, the plan was to attempt transcatheter edge-to-edge repair. It was a technically challenging case because of this large flail gap. You can see this flail segment right here by 3D imaging. The patient underwent deployment of 2 mitral clips and had significant improvement in the degree of mitral regurgitation. So again, 3D imaging and anatomical characterization of these lesions is important for procedural planning. This is the baseline pulmonary venous flow in this patient, and you can appreciate the systolic flow reversal followed by an upright systolic wave after the clips were deployed. This also resulted in an improvement in the LVOT stroke volume. This is a case of secondary or functional mitral regurgitation, and this is usually caused by LV dilation. You can see that the posterior leaflet is restricted, and you can appreciate that malcoaptation gap right there. You can see it over there. This resulted in significant mitral regurgitation, as you can appreciate by color Doppler, and this is 3D imaging of that same valve, demonstrating how restricted that posterior leaflet is. Similarly, the patient was at a high risk for surgery. He was optimized by our heart failure colleagues, continued to have significant mitral regurgitation, and ended up having 3 mitral clips with significant reduction in mitral regurgitation. Another cause of acute MR is papillary muscle rupture. Don't forget this cause of MR when you're evaluating patients, especially those who present late after an MI. This is a case of papillary muscle rupture right there. You can see it flopping back into the left atrium, and it's accompanied by significant mitral regurgitation. The anterolateral papillary muscle is less likely to rupture as it has dual blood supply from the LED and the left circ. The posterior medial, however, is more likely to rupture because it has a single blood supply by the PDA. When you see this, especially when you have a patient with an MI, make sure to contact your surgeons. This is a surgical emergency. So make sure you auscultate everybody who presents with ACS, especially late presenting ones. Let's talk more about characterizing the jet. We've talked about determining the mechanism, which has implications on management options. What about determining the severity? Again, remember that timing of the jet is very important. In cases of prolapse, your jet can be happening in late systole. So you don't see any regurgitation here in early systole or mid systole, and then you can see the jet here in late systole. And again, this is a continuous wave Doppler example of that late systolic jet. Timing is everything. Sometimes you see mitral regurgitation in diastole. And when does this happen? It usually happens when your left ventricular end diastolic pressure exceeds your left atrial pressure. And these can be seen in cases of AV block and severe aortic regurgitation. So again, once you see mitral regurgitation, make sure you pay attention to the timing, and a continuous wave Doppler can help you determine the timing of the jet. Some of the color Doppler parameters we use to evaluate mitral regurgitant lesions include the regurgitant jet area, but a lot of factors can influence this parameter, including the transvalvular pressure gradient, entrainment, and the Coanda effect. This is an example of a central jet where the entrainment of blood cell makes the regurgitant jet appear larger. And remember that color Doppler is a velocity map. So this central jet is attracting more RBCs, and the jet just appears larger visually. The Coanda effect is when you have these super eccentric jets. These are a couple of examples. And a fluid is usually attracted to nearby surfaces. And as it is, friction slows the velocity, and that reduces the size of the collar jet area. So visually, you can underestimate mitral regurgitation severity by looking at the jet area in such eccentric jets. So be careful when you see those eccentric jets. These, again, are different components of the regurgitant jet. You have your flow convergence, your vena contracta, which is the narrowest part of the jet, and the jet area that we talked about. So it's important to focus on what's happening proximally right here. We're always focused on the color and what's happening in the left atrium, but it's important to focus on this area of convergence and the vena contracta. You're all familiar with the concept of proximal isovelocity surface area. So basically, you're looking again at this area of flow convergence. The assumption here is that this is hemispheric. So you're using the radius to calculate the area of this area of proximal convergence. If you multiply the area by the aliasing velocity right here, which you have to make sure to shift towards the jet. If you multiply the area by the aliasing velocity, you end up with a regurgitant flow. The effective orifice area, which is right here, is calculated by dividing the regurgitant flow by the peak velocity of the jet as determined by the continuous wave Doppler. The regurgitant volume is then determined by multiplying your effective orifice area right there by the TVI of this regurgitant jet. So the PSI method enables you to determine the effective regurgitant orifice area and the regurgitant volume. However, this method is not without limitation. It's not applicable when you have multiple jets. It's less reliable in eccentric wall-hugging jets. And again, it assumes that your regurgitant orifice is circular or hemispheric. And any small errors in measurements of your radius can lead to significant errors in your determination of the effective regurgitant orifice. And your maximal PSA might not always coincide with your maximal V velocity by color dot, by continuous the wave Doppler, if it's not holosystolic, like in the cases we've seen earlier. And remember that there's a difference between primary and secondary MR. If you look at these 3D images of the vena contracta between primary and secondary MR, you can appreciate that the vena contracta in secondary MR is more elliptical or more oval shaped. So using PSA can significantly underestimate the degree of mitral regurgitation in this case. Volumetric assessment is another way of looking at MR severity. And you can do that by determining the stroke volume through the mitral annulus by using the mitral annular area and the flow across the annulus. And again, using the LVOT stroke volume. By subtracting the LVOT stroke volume from the mitral annular stroke volume, you end up with your mitral regurgitant volume. Again, a method not without limitations. It's not valid when you have aortic regurgitation because that will affect your flow. The annulus in this case, again, is assumed to be circular, and any small errors in measurement can lead to substantial errors. Another method of doing this is determining your LV stroke volume by the Simpson method by biplane, and then subtracting your LVOT stroke volume from your biplane stroke volume. Again, limitations, in addition to what we've mentioned earlier, include foreshortening and sometimes the need for contrast to make sure you're getting accurate end-systolic and end-diastolic volumes. The guidelines emphasize that it's important to integrate multiple parameters when you're evaluating mitral regurgitation severity. Some criteria are very specific for severe mitral regurgitation, others are specific for mild mitral regurgitation. And when you don't have enough specific criteria, you can go on and do more volumetric assessment before you deem a regurgitant lesion as severe. When you're not sure and you still have a question, you can always resort to T or CMR for further quantification. Specific criteria for severe MR include a flared leaflet, vena contracta width of more than or equal to 0.7 centimeters, a PSA radius of more than or equal to 1 when the aliasing velocity is 30 to 40 centimeters per second, large central jets occupying more than 50% of the left atrial area, pulmonary venous flow reversal, and enlarged LV with normal function. If you don't have 4 of these specific criteria, you can determine your effective regurgitant orifice area, regurgitant volume, and regurgitant fraction to increase your specificity for severe mitral regurgitation. After you've determined the mechanism and the severity of mitral regurgitation, things to look for include consequences of a significant lesion. And these include left atrial enlargement, left ventricular enlargement, and dysfunction, in addition to pulmonary hypertension. This is a 46-year-old male who presented to our valve clinic with severe dyspnea on exertion. And this was his baseline TT, the first echo he's ever had in his life. And you can see that he had a flail posterior mitral leaflet. His LV was significantly dilated. His EF was depressed. Look how huge his left atria was. And again, you can appreciate the LV dilation and dysfunction. And he had severe mitral regurgitation secondary to this flail. His PA systolic pressure was 55. You can see all the different consequences of this chronic mitral regurgitant lesion secondary to the posterior leaflet flail. He was sent for surgery and underwent surgical mitral valve repair. This takes us to management. After you've determined the mechanism, the severity, and once you've screened for the consequences of these lesions, then the guidelines tell us that if you have primary MR that's severe in the presence of symptoms, then surgical management is indicated. Your assessment becomes even more important when these patients are asymptomatic. In that case, if your left ventricular end systolic dimension is more than or equal to 40 millimeter, or if your PA systolic pressure is more than 50, or if your EF is between 30 and 60%, that's also an indication for an intervention. So again, your evaluation can also determine the management. So always be careful when you describe these lesions and make sure you include all these different numbers to help guide management plans. What about secondary MR? 2018 was really the year of secondary or functional MR. There were two studies describing the effect of edge-to-edge repair with a MitraClip device for functional mitral regurgitation in patients who were optimized from the medical standpoint. And these two trials showed completely different results. The MITRA-FR trial did not show any benefit in terms of hospitalizations or mortality benefit when the clip was used. And this is in contrast to the COAP trial that showed significant benefit in terms of reduction in hospitalizations and also showed mortality reduction with the edge-to-edge repair. And these two trials helped us understand that patient selection is key when you're dealing with secondary mitral regurgitation. If you look at the inclusion criteria of the MITRA-FR versus the COAP, the inclusion criteria for MITRA-FR included patients with effective regurgitant orifice areas of more than 20 millimeters squared or regurgitant volume more than 30 cc's. In contrast, the COAP used the severe functional mitral regurgitation criteria as set by the US guidelines, where the effective regurgitant orifice area was more than 30 millimeters squared or the regurgitant volume was 45 cc's. If you look at the population that was enrolled was also significantly different in that the effective regurgitant orifice area was larger in the COAP cohort and the LV and diastolic volume was smaller. So more severe MR with smaller ventricles. And that kind of gave rise to this new concept of proportionate or disproportionate MR. The way to look at it is that proportionate MR basically means that there's a linear relationship between the LV and diastolic volume and the effective regurgitant orifice for any given EF. So if you have any remodeling and enlargement of the left ventricle, this leads to apical and lateral displacement of the papillary muscles, and this leads to widening and flattening of the annulus, leading to malcoaptation of the leaflets. And this in turn gives rise to mitral regurgitation, which is proportionate in this case. On the other hand, disproportionate MR is when you have MR that's greater than you would expect just from these changes in the LV and diastolic volume. And these can be caused by ventricular dyssynchrony due to electrical conduction delay or any localized LV remodeling causing wall motion abnormalities in the inferior-posterior or lateral walls. When these things happen, you end up with dysynchronous contraction of the leaflet supporting structures, excessive tenting of the leaflets, and that's independent of the global LV geometry. This causes disproportionate MR. And when we plot these two trials against the disproportionate MR, you can appreciate that the co-opt cohort were more in the disproportionately severe MR as compared to the mitral FR cohort. So these are just new concepts that are being studied now in further characterizing secondary mitral regurgitation. So echo is definitely first in evaluating mitral regurgitation, but why is CMR very important? I think CMR is very important when you're looking at multiple mitral regurgitant jets, where you're looking at eccentric jets that are challenging to evaluate by echo. When you have any discrepancy between what you're seeing by echo and how the patient feels, if the patients are extremely symptomatic and you're only seeing moderate MR by echo, then make sure to evaluate further. It's also very useful for quantification of cardiac size and function, evaluation of LV scar, which has prognostic implications, and when you have multivalvular disease, like MR and AI. All right, a few words on aortic regurgitation. Again, an example from our valve clinic. This is a 31-year-old male who presented with severe dyspnea on exertion. This is the peristernal lung axis view, and can you appreciate the LV dilation, depressed function. The jet here is very eccentric. You can't really see it in the LVOT that well. If you look at the M mode through the mitral leaflets, you can notice that there's premature closure of the mitral valve leaflets. So your mitral valve closes right there, and your R wave is right here. So there's premature closure of the mitral valve leaflets. By short axis, this is the view that helps us determine how many cusps patients have. This is important when you have aortic valve disease. This patient had a unicuspid aortic valve, so only one cusp, and that was leading to severe aortic regurgitation. And this is your peristernal, your apical view showing that eccentric aortic regurgitant jet. Again, a CW through the jet. You can appreciate that the backflow, the diastolic jet, is as dense as the forward flow jet, which speaks of the severity of this lesion. The patient again was referred for surgery and underwent aortic valve replacement. So again, evaluate for the mechanism, severity, consequences, because that can guide management. So what are the different mechanisms of aortic regurgitation? So type 1 is caused by normal cusp motion with aortic dilation. So it's either in the sinuses, sinotubular junction, or the ascending aorta, or it can be caused by any cusp perforation, and this can be caused by infective endocarditis. Type 2 results from cusp prolapse, and type 3 can result from cusp restriction. So you have restricted, the leaflets don't co-opt well. These are the color Doppler parameters when you're describing aortic regurgitation. So you have the jet width. Make sure you evaluate this in the peristernal lung axis view, and you want to determine how much of the LVOT this jet is filling, the vena contracta, which is the narrowest part of the jet, and the jet area. Again, the M mode can be helpful, especially in acute aortic regurgitation cases where you have premature closure of the mitral valve. Volumetric assessment can also be very helpful. You can still use Faza in aortic regurgitation. You want to shift your baseline velocity, look at the area of proximal convergence, and you can determine your effective regurgitant orifice, similar to how you would do for mitral regurgitation. Again, always remember to look at the area of proximal convergence. It's always easy to be distracted by the downstream color jet, but this area can tell you a lot. If this is a large area of convergence, it means that the jet is probably severe. Using the peak velocity, again, you can do your Faza calculations and calculate your effective regurgitant orifice area and regurgitant volume. You can also use the stroke volume method, where you subtract your mitral valve stroke volume from your LVOT stroke volume to determine your aortic regurgitant volume. And remember, you cannot use this when you have mitral regurgitation. Pulse wave and continuous wave Doppler parameters include jet density and deceleration time. So you look at the regurgitant jet and compare it to your forward flow right here in systole. And if it's dense, like in this case, that kind of tells you that the severity of the lesions is more than mild. You can also look at this deceleration rate. So if you have a short half time, that usually indicates a more severe lesion, but beware that this can be affected by high LVEDPs as well. So each method you use has limitations. So when you're looking at a lesion, that's why you have to incorporate different methods, different parameters, understanding that each one has its own limitations. Holodiastolic flow reversal in proximal descending aorta is another parameter, but again, it has a lot to do with the arterial compliance. So again, not without its limitations. Similar to mitral regurgitation, the guidelines tell us to use multiple parameters when we're evaluating aortic regurgitation. Some criteria are specific for severe AI, and these include flare valves, vena contracta with more than 0.6, a central jet that occupies more than 65% of the LVOT area, a large area of flow convergence, a short pressure half time of less than 200 microseconds, a prominent holodiastolic flow reversal in the descending aorta, and an enlarged left ventricle. If you don't have 4 of these specific criteria, you can go on and do your volumetric assessments, looking at your regurgitant volume, your regurgitant fraction, and your effective regurgitant orifice area. All these can increase your specificity for determining the severity of aortic regurgitation. And if you're unsure, then you can always resort to TE or CMR for further quantification. MRI plays a vital role in evaluating aortic regurgitation. First, by identifying the mechanism of aortic regurgitation, it can help you with the quantification of severity, especially in the cases of multivalvular disease. You can evaluate for LV remodeling and LV scar, and you can screen for potential associated aortopathies because you get the view of the aorta at different segments. Management-wise, again, like any other valvular lesion, when you have severe symptomatic aortic regurgitation, then an intervention is indicated. When you have asymptomatic patients, your evaluations are important because if your EF is less than 50%, if your end systolic diameter is more than 50, or if your end diastolic diameter is more than 65 millimeters, then that's also an indication for an intervention. So my take-home points is make sure to determine the mechanism, the severity, and the consequences of each regurgitant lesion. It's like solving a puzzle. You want to get all the pieces and you want to understand that each method has its limitation. Special thank you to Dr. Little and Dr. Shabrulu for sharing some of their cases. Thank you so much for being with us today.
Okay, and so Nadeen, that was a wonderful intro and a wonderful explanation of the role of echocardiography and a nice segue to where CMR could be helpful. And obviously we want to make sure we have some time for questions at the end. If you have any questions for Nadeen, please go to pollev.com and enter DeBakey or text DeBakey to 37607, and we'll make sure we have some time for questions after I finish here. So let's start off with a case. This is a 40-year-old woman who is referred for evaluation of mitral regurgitation that was noted on echocardiography. And I think Nadeen very nicely pointed out that here's an example, if you look at the lower right-hand column, of a patient who's got a very eccentric mitral regurgitation jet, and that sometimes can be challenging to quantify by echocardiography. So that's the reason the patient was referred to the CMR lab. So at first glance, this is kind of the set of images that we get, the short axis as well as the standard long axis views, a 3-chamber, a 4-chamber, and a 2-chamber view. But I actually want to go into more detail and really dissect how we approach this. And I think similar to...
I want to share your we're not seeing it.
You're not seeing the screen? Okay, guys.
No, not on the big, you may want to share it.
Okay. No, I'm in the studio, so let me go back here for 1 second. They're going to just switch. They're going to just switch over to get mine to be the one that broadcasts out. Let me know. Do you guys see the screen now?
Not yet on Zoom.
Not yet. Okay.
There you go.
There we go. Okay. So now we've got it on Zoom and on LiveStream as well. So this is an example of the case. A 40-year-old with a very eccentric mitral regurgitation jet. Referred to the CMR lab for assessment of this. And obviously, first line, we're going to get a set of the short axis cine images and the standard long axis views, the 3-chamber, the 4-chamber, and the 2-chamber view. But let's go through and dissect what do we really want to try to accomplish in the time while the patient is in the scanner. And I think just like Nadeen talked about with echocardiography, the goals with CMR are really threefold. One, obviously, is you want to identify the severity of this valvular lesion. 2 is get some insights into the mechanism of the abnormality. And then 3, look at the consequences that this lesion has on this patient's heart. Because ultimately that's what's going to drive your decision making as far as management. We'll touch quickly on some studies that have compared echo and CMR for regurgitant assessment. And then really kind of wrap up by saying when is it that you would think about using CMR for assessment of valvular regurgitation. So I think the first principle that I want to start off with is that there should be, in the absence of any valvular regurgitation or an intracardiac shunt, there really should be equivalence of flow through all the chambers of the heart. And what I mean by that is if we look at what the RV stroke volume is, should equal what the left ventricular stroke volume is, and that should equal the aortic outflow, and it should equal the pulmonary outflow. So if we have the ability to solve for all 4 of these measures, then we can simply compare for differences to see if there is regurgitation present. And I'll go through now and walk you through how we do this. So let's talk about for mitral regurg, which we're going to touch on first. Obviously, we know that this principle would apply, which is that the LV stroke volume, which is whatever the left ventricle is ejecting out, should be equivalent to the flow that's going forward across the aortic valve. And then whatever difference there is would be the flow that's going backward across the mitral valve or the mitral regurgitation. Well, now we have a very good way to determine the left ventricular stroke volume, and that's by that stack of cine images that I showed you, the short axis views, where we can planimeter the end diastolic and end systolic contours to determine what the left ventricular stroke volume is. We can use a technique that I'm going to tell you about in a second to measure what the flow is coming out of the aorta, and this is called phase contrast CMR, and then simply subtracting the 2 will give us the mitral regurgitation. And as you'll see, we'll talk about not just during today's lecture, but also in some subsequent lectures, that the advantage of this methodology is it's a purely volumetric technique, and it doesn't matter if there's a changing degree of mitral regurgitation throughout systole. It doesn't matter if there's eccentric jets, if there's multiple jets, because you're simply identifying what is the total volume of mitral regurgitation for that cardiac cycle. And as we'll learn in one of the later lectures, this equation and this methodology actually works just fine even in the setting of aortic regurgitation mixed with mitral regurgitation, because aortic regurgitation will increase both the LV stroke volume as well as the aortic forward flow, and therefore it cancels itself out. So more on that, I think, in a subsequent lecture. But again, so when we talk about LV stroke volume, I think one of the strengths of CMR, I think we're all aware of, is the ability to do volumes without really any geometric assumptions. So we get a stack of short axis cine images from base all the way to the apex of the heart. Some key things are to make sure that your slices go all the way up to the very annulus or higher even, so that you don't lose any volume of the ventricle. You do this and you summate these together in end diastole, you summate all of these together in end systole, and therefore that's your left ventricular stroke volume. The phase contrast CMR, which is kind of the equivalent to echo Doppler, but it has some distinct differences as well. And this is an example of what this technique looks like. And again, it's typically done with a single breath hold, or it can be done in patients who have trouble with breath holding using a free breathing multi-average technique. And what it generates for you is really a series of frames at different points in the cardiac cycles. And on each frame, the velocity of each pixel is encoded here and is displayed based by intensity as well as direction. So we can see here In this patient, flow in the ascending aorta, which is going in the head to foot direction, is white in color, whereas flow in the descending aorta, which is going from from the head to foot, is the flow in the descending aorta, that's black in color. So we know that these are flow that's going in opposite directions. In addition to that, the intensity of the color, whether it's white or black, will be encoded based on how high the velocity is. And then on post-processing tools, we can actually draw an ROI. It will summate this together and give you a flow curve, which looks like I see over here, which actually is telling me what the total flow is that's happening through this systole, which in this example patient here was 93 mLs. And from our cine images, we computed that the left ventricular stroke volume for this patient was 176 mLs. So therefore, the mitral regurgitant volume is going to be the difference between these two, which gives us 83 mLs of mitral regurgitation. And then for regurgitant fraction, we would just take that regurgitant volume and divide it by the LV stroke volume in the absence of any AI, or a surrogate for what is the mitral inflow to determine how much of the forward flow coming across the mitral valve is actually regurgitating backward. And in this patient, that came out to close to 50%, 47% mitral regurgitant fraction. Now, one of the other things that you want to do, just like Nadeen talked about in echocardiography, is you want to have multiple checks and balances in place. So one of the things that we'll typically do, although for mitral regurg, we look at the LV stroke volume to the aortic forward flow, we'll also compute what the pulmonary artery flow is as well. And this is just an example of the phase contrast in our patient that's done at the pulmonary artery level, or just above the pulmonary artery. And this tells us what the flow is in the pulmonary artery. And where that's useful is because the difference between the LV stroke volume and the net pulmonary artery flow should also be similar to the difference between the LV stroke volume and the aortic outflow. And so if for some reason your aortic phase contrast is messed up, is problematic, or you forgot to do it, you can always rely on this method as a backup method to compute what the mitral regurgitation is. Now there's some caveats to all of these, so you need to know specific situations where some of these backup techniques do not apply, but certainly in the setting of an isolated mitral valve lesion, you could do this second methodology, or in fact, you could even do just computing the difference between the LV stroke volume and the RV stroke volume, because again, if there's isolated mitral regurgitation, that difference should be equated to the amount of mitral regurgitation. And so, there's different settings in which one may be preferable over the other, but I think this is kind of the hierarchical approach that we take. We start with equation 1. If for some reason there's a problem with that, we go on to 2, and then we go on to step 3. And then, in addition to those quantitative methodologies that we have, there's also some semi-quantitative methods that we can utilize to, again, look for corroboration. One is looking at the anatomic regurgitant orifice area. So this is basically, again, by doing cine images that are done now through the mitral leaflet tips, and we're able to determine what the size of the regurgitant orifice area is. So this is an anatomic area, but there's data showing that a ARO of greater than 0.4 centimeters is fairly sensitive and specific for identification of significant mitral regurgitation. And so again, this is a technique that we'll sometimes utilize as a backup if all of our volumetric methodologies for whatever reason did not work out. And you also utilize this as a way to increase your confidence in your numerical measurements, because you want to see consistency across all techniques that you have. Next, let's talk about mechanisms. So obviously, here's an example of a patient, a normal patient with, or a normal mitral valve, I should say, where you can see there's just a small amount of physiologic mitral regurgitation. Now, here's another case, and this is a case where you can see there's actually systolic turbulence in the left ventricular outflow tract. There's systolic anterior motion of the anterior mitral leaflet, resulting in posteriorly directed jet of mitral regurgitation. So this is a SAM-mediated mitral regurgitation jet. Now, in this setting, the way that you're going to try to compute the mitral regurgitation may be a little bit different. And the reason for that is you don't want to try to measure flow in the aorta here, which is past an area of turbulence. So in a setting like this, I would actually go to the second equation that I showed you, which is basically to compute the mitral regurg based on the LV stroke volume minus the net PA flow, because the aortic flow in this case may be underestimated because you're measuring flow after an area of turbulence. Now, here's examples of patients with mitral valve prolapse. You can see on the right-hand side is a patient who has predominantly a posterior leaflet prolapse. On the left-hand side is a patient who has really a bileaflet, large billowing mitral leaflets, and this is really consistent with a Barlow's type picture. We know that certainly there's a spectrum here, but that there are some differences between patients with Barlow's disease versus fibroelastic deficiency, which tends to lead to more of a single leaflet prolapse type picture. The Barlow's or the bileaflet patients tend to be much younger. The pathology is a little bit different as well. The murmur that you may hear may be different, where oftentimes in the patients with bileaflet prolapse, you hear more of a mid-systolic or late systolic murmur. The goals with CMR is not just to identify the presence of prolapse or the presence of an abnormality of malcoaptation, but also to try to localize it. And here's what you'll typically do. If you look at the short axis view that we do here through the mitral valve, and this middle line that's in yellow here is a three-chamber view. Well, instead of just getting one mid-ventricular three-chamber view, our goal is to really get a series of these, a stack of these three-chamber views that go through the more anterior interfaces, which would be the A1, P1, as well as more inferiorly, which would be the A3, P3. And as we go through and look at these and look at the coaptation, you'll notice that the primary coaptation abnormality is down here when we get down to the very inferiorly near the A3, P3 interface. And then there's data showing, in fact, that when it comes to localizing the abnormality and whether it's which leaflet is affected, whether it's an anterior or a posterior leaflet, CMR performs reasonably well in this study, which compared CMR with transesophageal echo using intraoperative surgical findings as a gold standard. And what you can see is that for both anterior as well as posterior leaflet abnormalities, there was fairly good performance. But I think it is one thing to keep in mind, which is that CMR is not as good as TE is for depicting torn chordae. And the reason for that is these are very highly mobile torn chordae, and CMR may have trouble identifying this when most of the images with CMR are acquired actually over multiple cardiac cycles. Now, I think Nadeen talked a little bit about the fact that there's primary MR, which is what we talked about up till now, but there's also patients who have secondary MR, which is more of a problem of the ventricle itself. And you can see in this person here who's got a dilated left ventricle with significant LV dysfunction, and you can see really an area of akinesis and almost aneurysm of the infralateral wall. You'll notice, although the mitral valve leaflets look fairly normal structurally, there is impaired restricted motion of the posterior mitral leaflet, resulting in this posteriorly directed jet of mitral regurgitation. We can couple this anatomic and functional assessment with tissue characterization that's done with gadolinium contrast. And we can see in this patient here that there's really a transmural infarct in this infralateral wall. And so therefore, the mechanism here is obviously an ischemic mitral regurgitation due to posterior leaflet tethering that's secondary to infralateral transmural infarction. Here's another patient where, again, you see a ventricle that's dilated and remodeled with significant left ventricular dysfunction. There's kind of symmetric tethering of both leaflets. And in this person, when we do our delayed enhancement MRI, we see no evidence of myocardial infarction or scar. And this is an example of a patient who has non-ischemic secondary mitral regurgitation. And then I'll show you another nice example here if you look at the atrium, you can see both atria in this patient are quite dilated, as is the mitral annulus. And you can see the leaflets are flattened at their coaptation. And this is an example of atrial functional mitral regurgitation. And in fact, if you look at the right ventricle, you can also see that looks like there's a significant amount of tricuspid regurgitation in this patient, which again is likely secondary to atrial functional tricuspid regurgitation as well. And we have a lecture coming up later in the season, which will talk about the role of CMR in the right side as well as tricuspid regurgitant lesions. So last, let's wrap up this section on initial assessment of valve regurgitation with talking about how we look at the consequences of the lesion. So I think the standard approach has been to look at linear dimensions. So here's an example of what the left ventricular end diastolic dimension and the left ventricular end systolic dimension is for this patient of ours with mitral regurgitation. But in addition to that, usually what we like to use with CMR is actually to look at global volumes, to look at global end diastolic and global end systolic volumes. And then for this patient of ours, you can see when we couple all of this together, we saw that this person had a problem with coaptation near the A3-P3 interface. We saw that they had severe mitral regurgitation with almost 83 cc's of mitral regurg. And when we look at the remodeling data, we can see that you have a very large left ventricular end diastolic volume as well as a left ventricular end systolic volume. And in fact, there's also some reduction in left ventricular ejection fraction. And you can see the left ventricular mass is increased as well, consistent with eccentric hypertrophy. And in fact, in this patient, it also looks like the RV as well is dilated and is dysfunctional to some extent also. And in addition to the ventricular chamber remodeling, it's also important to look at atrial sizes. And so this is kind of the standard clinical methodology that we will utilize, which is a biplane area length method, similar to what's done in echocardiography, where you'll planimeter the size of the left atrium on a 4-chamber and a 2-chamber view to get the area, and then use the length, and then similar formula that's used to echocardiography to determine a left atrial volume. Important to keep in mind that normal left atrial volumes by CMR and CT are quite a bit larger than normal left atrial volumes by echocardiography. So the upper limits of normal by CMR is about 52 to 53 milliliters per meter square. So I think you want to make sure that you determine the presence of the left atrial enlargement based on normal values that are for the specific modality. Beyond these linear dimensions and volumes, I think the other thing that CMR can provide when we talk about consequences of the lesion is really the assessment of myocardial fibrosis within the left ventricle. So I'll show you an example of a patient with mitral valve prolapse. And you'll notice if I show you the delayed enhancement MRI image in the middle here, that there's actually an area of high signal or hyperenhancement in this basal infralateral wall. And here's a cartoon just showing that very nicely. And again, this is something that seems to be uniquely associated with mitral valve prolapse. This fibrosis pattern doesn't occur in patients who have mitral regurgitation without mitral valve prolapse. And in fact, in this series, we found that patients with MVP have a higher and an increasing rate or prevalence of fibrosis primarily in the infralateral wall, in the posterior papillary muscle segments, that increases with severity of mitral regurgitation, whereas the patients without mitral valve prolapse, there's really a low prevalence and it's not related to severity of MR. Now, where this information can be useful is in the mitral valve prolapse patients. There's also a signal, at least, that the presence of this fibrosis in patients with MVP seems to be associated with an increased risk of arrhythmic events. And this was obviously a small series, so there's multiple works being done to try to look at this in a much larger fashion. But again, I think it's the unique information that CMR is able to provide you with beyond simple severity as well as mechanism is really the consequences which go beyond volumes and ejection fraction and really show you what it does at the tissue level. Now, how does CMR compare with echocardiography? And I think I'll be the first to say that really the two modalities to a large extent are complementary to each other. And obviously, I think you're going to start off with an echocardiogram first. Here's one study which looked at CMR and echo grading of mitral regurgitation. And the objective here was to say, let's look at reverse remodeling after mitral valve surgery and use that as a reference standard for the likely amount of mitral regurgitation at baseline. And this study, what they found was that there's a pretty tight relationship between the baseline amount of mitral regurgitation and the reduction in LV size after mitral valve repair or replacement. And I think the question always then comes up, okay, so what are the cases? Is every case that should go on to get a CMR? Are there certain scenarios where we can expect to see a discordance? And so this was a very nice study that came out a couple of years ago, which looked at a series of over 250 patients that underwent mitral valve surgery, underwent follow-up of asymptomatic organic mitral regurgitation. And what they found was that about a quarter of the patients had a discordance in assessment of severity between CMR and a transthoracic coupled with a transesophageal echo strategy. And these are the three scenarios where they found most of the discordances happened. One was when there was a late systolic jet. So again, in those patients with Barlow's disease, where the severity of the mitral regurgitation changes throughout the cardiac cycle. Another was in patients who had multiple mitral regurgitation jets, where it can be hard sometimes on echocardiography to kind of summate the total amount of mitral regurgitation. And then the third was in patients that had very eccentric mitral regurgitation jets, as in the example patient that we started off this lecture with today. And what they found was that CMR grading of severity was associated with likelihood of development of symptoms and subsequent need for mitral valve surgery. Now, let's turn to the aortic valve. And again, I think with the aortic valve, our approaches are the same. Not only do you want to try to quantify the severity, but also look at the associated abnormalities and the consequences. With AI, I think it's important to recognize that oftentimes you can have a variety of different valve structural abnormalities. Here's a patient who has a bicuspid aortic valve. Here's an example of somebody with a quadricuspid aortic valve. And so our goal is not only to quantify severity, but also look at the valve itself. And then in addition to that, look at the aortic root as well as look at the ascending aorta. Because we know that patients, especially with a bicuspid or unicuspid or a quadricuspid valve, can oftentimes have associated aortopathy. And this can affect not just the root, but oftentimes it can affect the ascending aorta. And then we also know for patients with bicuspid valve, we also want to look for an associated coarctation in the aortic isthmus. So these are all things that you're typically going to do when you do an aortic regurg assessment by CMR. Now, the quantitative methodology with AI is actually a little bit different in the sense that the preferred way is actually to look at the phase contrast in the aortic root just above the aortic valve. And you're basically measuring the column of blood that's coming retrograde during diastole. And here's an example of what that would look like. And you can see in this patient here that we have flow that's retrograde throughout all of diastole. If we summate this volume together, we get about 80 cc's of aortic regurgitation. Now, in addition to that direct methodology, there's also indirect methods that we can utilize. One of these is to look at the left ventricular outflow tract forward flow and compare that to the pulmonary artery net flow. And then the last one is to look at the LV stroke volume minus the RV stroke volume. And again, the last methodology would only work if you're dealing with isolated aortic regurgitation. The advantage, though, of these two indirect methods is that sometimes with aortic regurgitation, which is primarily a diastolic phenomenon, if you have atrial fibrillation where there's significant variability in the RR intervals, a direct diastolic measurement may be challenging, and it really may be variable from cycle to cycle as well. And in those cases, we can actually look at the systolic forward flow across the LVOT and compare that to the systolic net flow across the pulmonary artery. And again, that difference should equate to your aortic regurgitation. Let me skip past this here. A couple of semi-quantitative techniques we can look at. Again, similarly look at the anatomic regurgitant orifice area of the aortic regurgitant jet. And there's data showing that an ARO of greater than 0.28 is fairly sensitive and specific, again, for 3+ or 4+ aortic regurgitation. And you can also look, similar to echocardiography, for holodiastolic flow reversal in the descending aorta. So you'll notice in that view that we get, when we see the ascending aorta, most of the time you also are able to visualize very nicely the mid-descending aorta, and you can simply contour this and determine what is the reverse flow at this location. And there's data showing that a holodiastolic reverse flow of more than 10 milliliters per second is also associated with 3 or 4+ aortic regurgitation. Let me wrap up. When we talk about patients who have prosthetic valves, in this case, this is a TAVR valve. If there's concern of paravalvular aortic regurgitation post-TAVR, there's data showing that CMR is very good at identifying the severity of this paravalvular leak, and that severity is correlated with clinical outcomes as well. So let me wrap up here, and then we have a couple of minutes for questions. So I think, when is it you would think about getting a CMR for valvular regurgitation? I think clearly when you have a technically limited echocardiographic image, when there's a discordance between the history, the physical, and the 2D Doppler findings, when there's an eccentric regurgitant jet, as we showed with our example patient today, when there's non-holosystolic mitral regurgitation, such as in Barlow's, when you have multiple jets, or when you have multiple regurgitant lesions, and we'll touch on this more in a subsequent lecture in a couple weeks. And then I think, importantly also, it's even when you know the severity of the lesion, when you want to try to accurately characterize the consequences of this valve lesion on the heart, both from a standpoint of quantification of volumes, of ejection fraction, also of assessment of the right heart, and then lastly for assessment of myocardial viability and scar. So thank you for your attention, and I'm going to open it up now for questions. Before I go to our questions from our internal audience, there is one that we got sent in to us via text, and it's, I want to ask you about post-operative mild AR after AVR. When to readdress this patient for redo surgery? Is there any specific timing for endothelialization of aortic annulus? Now, I presume you're probably talking about AVR being percutaneous or transcatheter AVR. Nadeen, let me open this up to you. You're obviously working day in and day out in our valve clinic. So you see a patient after a TAVR, and there's some paravalvular aortic regurgitation. How do you approach this patient?
Thank you, Dr. Shah. So yes, we see a lot of TAVR patients, and some of them have mild aortic regurgitation. I would refer back to the guidelines for the assessment of regurgitation after transcatheter interventions. Has very nice figures and images to show you how you can quantify that lesion accurately, because that's the first thing you want to do. Most of the time, if it's mild, then we just watch it. Patients usually get a 30-day echo post-TAVR and a 1-year echo, and usually these lesions don't change. If the patient comes in post-TAVR or post-surgery and you see mild AI by echo, but the patient's very symptomatic, then it's worthwhile getting extra set of imaging, sweeping, making sure you're seeing the whole jet, evaluating its origin, the extent, how much of the circumference it occupies. And if there's a question, you can always get a TE or a CMR to better evaluate it. It's also important to evaluate the location. For example, in surgical aortic valves, if it's paravalvular, then you have the option of doing a percutaneous PVL closure versus if it's a central, that's not an option. And it's sometimes hard to evaluate the location because of the acoustic shadowing caused by the valve. So when you're seeing these patients, especially post-TAVR, mild TAVRs, no symptoms, there's no indication for intervention. If patients are symptomatic, you start trying to get more images to make sure it's only mild and that you're not missing a more eccentric jet. And again, the localization, whether it be central or perivalvular, can have different implications for management.
Yeah, and the one thing I'll say, to me, it seems that the valves, compared to the first generation TAVR valves, the valves have gotten better as well. So we're seeing much less of the paravalvular aortic regurgitation than I think we saw in the very early days. Do you agree with that?
Absolutely. Now they have skirts that seal and decrease the amount of regurgitation, paravalvular regurgitation.
Okay, so we've got maybe a time for one or two more questions. Anybody from our internal audience on Zoom have any questions for Nadeen or myself? Please unmute yourself. Or did we address everything completely? Okay. Well, I guess we answered all their questions. So, all right. Well, thank you very much, Nadeen. Wonderful presentation as always.
Thank you,
thanks
Dr.
to the
Shah.
audience, and then we'll see you all again same time next week.
Thank you.